Good evening, everyone. My name is Dr. Sinan. I'm an orthopedic surgeon in Al Kindi Hospital and Imam Ali Hospital in Baghdad. I worked for 5 years in this career, and actually, I'm very fond of the hip arthroplasty reconstruction surgery and sport medicine for the last 2.5 years. Especially in AORICON, I'm a member here. And then we will share these ideas and webinars with you as what the AORICON have proposed to us. So in this lecture and this webinar, we will start recording. So I have to put suggested admitting. You are warm welcome, and I'm honored to be all with us. And we will start by this moment for the hip instability, and it's about a few minutes later because many admissions. Okay. Today, we will start for this lecture and then another lecture about the stem variables, especially in cementless systems in the total hip arthroplasty. As you all know, the hip arthroplasty have a successful rate in these years, and the success is dependent on many factors, especially when the surgeon have got the principles of total hip replacement. So after that, with the invent of the new generations of implants, with the many of us can see how the hip functional outcome is increased by from 10 years follow-up into 20 years of follow-up. But however, there are so many dislocation rates. The dislocation now is most common, one of the most common complications. So as we see, it's most common complication and one of the most common complication because there are any other risk factor like the infection, pain, and instabilities come third. And for the primary, there are variables from 1 to 10% with the primary arthroplasty, and for the revision is up to 27%. So in most these initial dislocation occur early, and these early is about from 60 to 70% as the first 6 weeks. And this makes a challenge for the surgeon and the patient as well. The etiology, we can divide it into three groups. The first group is the patient factor, the second group is the implant, and the surgery is the third. So the patient factor depends on the demography of a patient. Like, for example, the gender, female is more than male, elderly more than 75, and the previous surgery. Actually, these have been shown that compliant for the soft tissue in women, they may contribute to a higher risk of dislocation than men. While those in elderly as well, the elasticity of fibers are decreasing during aging process, and the previous surgery due to change in the surgical fibrosis and increasing that cause dislocation when the soft tissue are very lax. The second thing is the inpatient factor is the preoperative surgery diagnosis, like a fracture of the neck and DDH and rheumatoid. You all know that there will be a common thing of these three. Some of them lack of a stabilizing capsular fibrosis and different preoperative and postoperative length when we have deal with a DDH dysplasia, which is CO4 and 3, soft tissue tension, and it is changing in the rheumatoid arthritis and their injury of of the stabilizing short external rotators. For the neuromuscular dysfunction, we can see that the higher risk of instability are due to control of the muscle is poor and changes in muscle balance is very weak, especially in CP and Parkinsonism, as well as in epileptic patients. The cognitive dysfunction have been shown to a higher risk than in alcoholic than non-alcoholic patients. Dementia is as well one of them have a potent factor for due to lack of ability to comply and activity restrictions. Remember that the BMI is a not related factor for the hip dislocation. However, in a severely obese patient, there will be changing in the abductor function. Also remember that soft tissue strains to dislocation for the hip are the glutei, medius and minimus, and the hip capsule in the form of iliofemoral, pubifemoral, and ischiofemoral ligaments. The other part of etiology is that, as we said, patient factor, this is the first one, and then we come to the implant factor. For the implant factor, the geometry, as the head neck offset, the head size, and linear profile, we will discuss it later. The polyethylene wear and deformation, and impingement after when we have a trunnion impingement of polyethylene. The trunnion is here between the head and the first part of the neck, and osteophyte there is an anterior. Here in this picture, we will show how can be done. The first of all is the head and neck, as you see. In picture A, you can see that the head is small in relation to the neck. Okay, so the head ratio is shorter, is lower. When there is a lower lower head-neck ratio, there will be an impingement free range of motion is decreased. So that's why this area is got a higher rate of dislocation because of range of motion due to impingement between the neck and the acetabulum, especially when we are dealing with a retroverted or excessively antiverted acetabulum, as well as, don't forget that the head ratio now is decreased, and then we can see that the impingement between the neck and the cup also has been done, as we see in the retro version, is from the posterior, and the anti-version is from the anterior. However, the inclination of the cup is also makes the dislocation risk higher, especially when we have got an abduction or inclination is more than 50 degrees. And that's why the head will go inferiorly dislocates. Here in this picture, in the other one, we see that the head-neck ratio is very high. So there is a higher range of motion free impingement, all right? So that's why we can use a higher neck-head ratio. This is related when we are increasing the offset with a skirted head. A skirted head here, this will cause a longer offset, but however, in spite of a good soft tissue tensioning, look at here, we have the free range of motion impingement point as a fulcrum here and will cause a dislocation earlier. Regarding the second thing, this is all about the head-neck ratio, which means that the head is larger size than the neck length. However, in this picture C, you can see when we are using a small head versus a larger head. A small head have a jump distance. A small head have a jump distance is higher than the larger side. So the larger side now, we have a range of motion better. A jump distance is higher in order to dislocate. The third thing is now we are dealing with the polyethylene liner. Polyethylene liner, this is the conventional, and these are the posterior liner support. A posterior liner support with a wedge shape or in the only posterior or a semi-constrained. Now these are having, like this one, an impingement free range of motion decreased. Here also, you can see it in the posteriorly when we added some of the polyethylene liner on the posterior side as an elevation here, there will be an impingement-free decreased. So that's why we can see a lateral dislocation when the hip is abducted. Okay. So the improper positioning of the cup and or the liner will cause an malalignment and malposition of the component and will cause an impingement. So it's all about fulcrum that causing dislocation. At the femoral side, do you remember that this only at the acetabular side? So the femoral side or excessive anteversion and this of the stem is associated is recently associated with hip instability, but improper version only when there is no modular type. We'll see what is meaning by modular type of a stem. We can change it simply and rarely cause the instability. Decrease in femoral offset, however, have higher risk of dislocation. When you reduce it, when you reduce the offset, it will cause tissue tensioning low. Like, for example, the abductors are very low to cause a tension. That's why some of them we'll see later a suggestion of a trochanteric transfer. So these liner options, you can see that this is the conventional type with the head is deeply seated. This one is laterally seated, which has a very long offset, but we have a range of motion free. And this is a posterior post. This is the posterior post of the liner. And then we have a dual mobility, and we will see what are the difference between both. So the third factor is that a surgery factor. Welcome. Surgery factor, now we will see how it is changing. Because of the modularity of the approaches, we can see that the anterior and lateral approach have a 0.6% of dislocation in the anterior. Anterolateral also anterior dislocation of 0.2, and posterior is the most common rather than the transtrochanteric approach. Remember that in the posterior approach, as in webinar 2, we suggested after implanting and proper implantation of these components, you have to restore the capsula and the short external rotator through these holes, and you bring it back and suture it away in the lateral wall of the greater trochanter. Again, implant malalignment is the most common cause of etiology in dislocation. As we see, the cup angulation, whether version and inclination, may cause a dislocation earlier. So the version, anteversion, when excessive anteversion, may cause a dislocation anteriorly, and retroversion cause posterior dislocation. Inclination also have an impingement anterior of the neck during range of motion, and it may cause inferior dislocation. Over-medialization at center rotation of the cup, which means that we make it shorter the lever arm of the body weight. And in order to increase the abductor, and this is decreasing the abductor, as well as it may cause a dislocation earlier. The femoral stem version, as we said, is really associated, but the offset will, when it is reduced, it's causing a decrease in the abductor tension. The third thing is that an extra-articular bony impingement that overhang the cup, or if you have a heterotropic ossification that causing impingement. And the last is the surgeon experience, as the surgeon may have got 100 cases of total hip. It's better to do that and better to control dislocation preoperatively. You can remember that the anteversion of the total hip, the combined anteversion, is between the cup and the neck. So you can see here the established shell here is in a 20-degree anteversion and 15 degrees from the head neck junction with the trochanteric line. And these are together may have got as a theta angle. So what about classification here in this part? We can classify the dislocation into according to the time dependent. For example, an early, less than 6 months, intermediate, 6 to 5 years, and late, after 5 years. The early and intermediate is related to neuromuscular disorder, compliance of the patient, implant malposition, and impingement. And usually, or sometimes, it may be treated with a closed reduction. While late dislocation, it is about aware osteolysis and loosening of the implant, stress shielding, and these are managed by revision surgery. The other classification is anatomic, and this is a thesis by 2012, which is the classification of unstable hip arthroplasty, depends on the anatomy. The first one is the acetabular component malposition. The second one is a femoral. The third is abductor deficiency. Impingement is a 4. Late wear and unresolved or unknown etiology is 5. This is. So how about management? You have to first clear understanding of the cause and a detailed history and examination. Don't forget any complication in periprosthetic dislocation. Periprosthetic, as a periprosthetic fracture, you have to rule out a periprosthetic joint infection. A proper x-rays have been made at true reasons for the dislocation, especially when you are dealing with the first 6 weeks. So the diagnosis can give a clue regarding the direction of the dislocation, the possibility of impingement, and component malposition. Physical examination is very important. The patient position and mechanism of injury that cause a dislocation, and examination of the general ligament laxity, muscle strength, especially the abductors, the limb length discrepancy if occurs pre and post-operatively after total hip, and the neurophysiological and neuromuscular deficits. The X-ray usually, we do a previous film, first of all, to identify any loosening of the implant and position of the cup, especially by a CT scan. Don't forget that the CT scan have to reduce the cross-sectional image, reduce the implant, it may reduce the implant glow. AP hip and AP pelvis are very important. In this view, we can see the anteroposterior view of the pelvis. And as you see, there is an anteversion, which looks good. But if you have a good X-ray technician who takes the anteroposterior view of the hip, it is a retroverted, and this is a dislocation of the femoral head away. Lateral view are also helpful in determining the version of the cup. However, CT scan is almost always the better. Regarding management, we can classify in the early, as we said, by close reduction. Reduction with the general or local anesthesia, you can track the patient and then put the patient in bed, rest for 6 weeks, and then using a cane. Direct extensively about the position to avoid. You have to avoid the extension and external rotation, especially in the posterior approach and vice versa. Bracing in recent studies does not recommend it because of the delay in muscle function. In cases for 3 times dislocation and late dislocation, revision is considered. Now remember that the classification of anatomical is this one. So isolated acetabular malposition is type 1, femoral malposition is type 2, 3 is abductor deficiency, and soft tissue deficiency, 4 impingement, and 5 polyethylene wear, and 6 is unknown. So management will be considered as such. Type 1 is a revision of the cup because of malposition of the cup, and exchange liner only if the cup is well positioned. Exchange the liner. There are many suggested liner like a constrained liner, and we will see it later. The type 2 is a stem revision because of the stem has been retroverted or verted exactly with that of the femur. You can exchange only the version in modular stem, and we will see in the next lecture what is the modular stem is. In type 3, revision of the implant, if a malposition, dual mobility cup, constrained liner, and soft tissue procedures. And remember that this is an abductor deficiency. You start with the implant. If there is no if there is good positions, you go for the soft tissue procedures. Increasing the head size does not change the abductor lever arm, which means that only the head size from 28 to 32 to 36. So only you can change the trinion depth, which means that the head, which is minus, into a medium or a large and extra large. In cases of a well fixed, you can do a trochanteric advancement surgery. The impingement cases, and increase the head neck ratio, increase the head, and increase the offset. It's only the best benefit from the impingement, and as well as we divide the impingement side. Type 5, which is the osteolysis and loosening, you have to revise the cup, all right, and the implant, all the implants. The unknown cause requires a careful care and pathology. If it is not identified, your dual mobility cup is the answer. And always close attention to hip biomechanics must be observed in all cases. This one is the dual mobility cup, and we will discuss it in this lecture. So the planning here. You can now go for this one. You can see the left and the right. If there is an unstable hip, you go for a compatible, correctable via polyethylene, or the component is right for the patient. Here you have unstable or malposition. You can see it when it is stable, everything is done. It's unstable, so it revise. Only polyethylene, okay? So you have a correctable via polyethylene. If yes, go for a stable. Yes, it's okay, done. But if it is not, you have to revision of the implants. Is the components are right for the patient, which means that is it not malpositioned, everything looks fine. So look for two things: leg length, when it is longer length or a shorter one. In longer lengths, you have to think about impingement, while shorter, you have to increase the offset or the leg length, the neck length. Increasing the offset if everything stable is done, it is not. Think about impingement. Impingement here, you have to remove the impingement. You have to check the neck head ratio. Everything is stable, it is done. If it is unstable, consider trochanteric advancement for the soft tissue. And here, if it is not very well or not applicable, or sometimes if there is femoral proximal femur loosened and door classification type 3, you have to check for stability, either a constraint liner or a dual mobility cup. So one of the methods we are treating with dislocation is a constrained liner. The constrained liner, you can see this is the prosthetic head, And this is the bipolar component, and with it, this is a locking ring. Locking ring locks this component, the bipolar, with the constraint system, which is the outer polyethylene liner and the metal shell. This is not mobile between those, but here, this will lock the head and the bipolar component together with inside the constraint system. What are the positives and the advantages and disadvantages? Here it is a limited use because there is a placement on, it can be placed on the de novo cup, and even we can cement inside it. Moderate success rate, however, in 86% in the midterm follow-up, but failure of loosening and redislocation is so high, especially, and have failure rates of 40% of dislocation, that this KM survivorship, one of the HIP scores, shows that 67% at 10 years. Meanwhile, these constraint acetabular liner are designed to lock the femoral head into the inner bearing surface. This will lead to a higher focus on acetabular cup. Consequently, these liners restrict the range of motion that cause prosthetic impingement, which can lead to unacceptable high failure rates. So the dual mobility cup is the answer. You can see that the head with the polyethylene, which is mobile inside the shell of the acetabulum. A widespread use is an option for dislocation risk factor. Whenever you see a risk factor dislocation, you can use it. Adding a mobile liner will increase range of motion to impingement. And you can see the survivorship time, although it is only 12 years, however, it is up to 98% of successful rate. The taper, these are the components of a dual mobility cup. Taper junction between the head and the stem, a small articulation between the head and polyethylene insert. This one is the articulation, polyethylene metal liner, when we are using the metal liner with screws. Sometimes it is not used when there is no screws, high porous coated, extensively porous coated stem without screws can be done, and this one is moving B with the D immediately. This is a metal liner in the US variation of the original French system. As you see here, the cross-section view of the modern dual mobility cup design in the chamfered edge of the retentive polyethylene rim. The configuration now allows a greater range of motion, as you see here in the impingement of the polyethylene and movement of the polyethylene inside the shell, unlike that of the standard bearing when the polyethylene is fixed into the cup. And you can see here, this study by 2016 shows that many hip surgeries have been shown in a very low rate of wear inside the polyethylene and metal backside wear. Okay, I'm thankfully enjoyed to tell you this conversation and the webinar. If there is any questions, I'd like to hear from you. And if you are going to, because you are many, mashallah, I wish that you can write it down in the chat. And thankfully, this part 1 of the webinar, part 2 will be done later after your questions. So please, you are free to ask.
السلام عليكم.
أهلا عليكم السلام.
دكتور سنان شلونك؟ حاشت لي على المحاضرة.
بيدك تكلم.
How the spinal fixation affect the cup position and stability of the hip?
Well, this is a very, very interesting question actually, and we answered previously in the first 2 or 3 webinars. The spine actually We are doing a total hip arthroplasty when you have a restricted lumbar spine and there is deformity in the spine, like a de novo scoliosis, or you have a sacroiliac joint disease. There will be position of the cup, which is more anterior, especially if you have the pelvic incidence is positive, like that of more than 52. I remember the figure is 55 degrees of inclination. Is that okay, doctor? Okay, I can't hear you. Um, Sorry, Dr. Saif. I will mute you all. I'm sorry, but there are many noise and you cannot hear me well. I think you have better to write it down in the chat group here. We can share each other the questions. Question by Dr. Raul Ortega. A dual mobility prosthesis, what percent of dislocation they do have? Actually, in the recent studies, Dr. Ortega, uh, recent studies is up to 17 years by the French team, which suggested that the dislocation rate is 0.3%. For the National Joint Registry in British, they suggested a 15 years of meta-analysis of many type 2, level 2 and level 3 studies, shows that there are less than 0.5% of dislocation at the minimum of 15 years, all right? So I think the dual mobility prosthesis, they do not have much dislocation. They are treating the dislocation actually. So please, if anyone have a question, write it down here. You are very welcome, Dr. Ortega. Do you have any more questions about this webinar? Okay, Dr. Bassam Mosleh, how are you? What are the differences between the true hip AP view, and pelvic view? Yes, this is a very important question. I remember that I see it in the orthopedic knowledge updates. They have suggested that the true anteroposterior view of the pelvis is regarding a standing view, and as you know, there is the internal rotation of the hip, both of them, and the pelvis is in line with the symphysis pubis and the sacroiliac joint, and there is no rotation, as you know. But the hip only, there are standards here. I read it in the radiology text. They suggested that the hip internal rotation is not mandatory here, first of all. And the second is that there is not a neutral pelvis. It's not true AP, because the hip only view, they suggested a little bit inclination of the beam, 5 to 10 degrees cephalad. You see I'm saying? Cephalad means that like when you are taking down the pelvis as an outlet view, okay? So that's why in the hip only, they suggested 5 to 10 degrees cephalad as the patient lies supine, with no rotation, of course. This is actually my question when I read it in the update. Okay, what are the difference between true AP and AP hip? Yeah, thank you very much. Okay, if there is any more questions, please. I think the net is weak with you so that you cannot write it quickly. I will wait for any questions you can and I can answer. How many degrees, Dr. Ortega, of angulation do you give your acetabular components? Well, for me, I actually goes for the kinematic version of the cup. And the kinematic means that the patient's specific version. I depend, first of all, on the TAL, the transverse acetabular ligament, and the anterior capsule, if there is no fracture or deficiency, and also the superior acetabular rim, the ischium, if there is a deformed acetabulum or there is a previous fracture, I depend on it in the inferior part. So there is almost always there is a overhang of the posterior wall. It is forgiven because a few degrees of a posterior overhang that are ensured for the anteversion. However, the tile must be in line with that of your cup, especially your tile cup. Your tile cup must be parallel with the tile. Again, for the inclination, I depend on the tile too in order to make it deeper. The cup is deeper 2 to 3 millimeters only from the transverse acetabular ligament. I think that's how I put the cup actually. You're welcome, Ortega. Ah, so this is Nicaragua. Okay, I'm sharing now. Can everyone see that? Yeah, I expect so. Greeting. Thank you very much, sir. Well, let's do this one. Please wait. We will have a share about the dislocation. No, we're on the show. Where are you? Uh-huh. Okay. I'm sorry for delay, and we will start the next lecture about the implants. Okay. Are you with me? I wish that. Ah, so the next lecture is about the implant design and the cementless hip arthroplasty. Actually, this only notes to know. There's nothing more than the stems of the hip. How are they classified? There are two classification systems. Callahan have shown that there is a modular, extensive coated, hydroxypatite, proximally ingrowth or proximally coated, the tapered, press fit, custom design. This is very difficult actually. When you read it, you will be just memorize it not very well. However, Montego in 2011 suggested a classification system that has based on the bone contact area and subdivision of fixation type. Okay, there are 6 types: a single wedge, metaphyseal filling, tapered, cylindrical, modular, and curved anatomic. The first is the single wedge. This is flat but in sagittal but wide in coronal, so that there are mediolateral contact. It is distally tapered, proximally coated, and the contact of proximal posterior femur, anterior cortex, and posterior cortex. Posterior femur in the proximal part. All right. So it is, for example, a taper lock system, and you have the double wedge, which is proximally coated and tapered distally, both in anteroposterior and mediolateral. It's almost always proximal coated like the first one. The contact between the metaphyses is both in proximal and distal, on the proximal only, with the anteroposterior and mediolateral. That's why it is called a metaphyseal filling or double wedge, like that of the summit in Dupuy. A tapered stem, you can see this is tapered both ends in the anteroposterior mediolateral. This is having a smooth curve, fixation in the metaphyseal diaphyseal junction, and when used in a narrow canal. This part is called the Mallory head design, and this is the Wagner system, and these are other types of rectangular type. Okay, and these are used when there is a severe bone deficiency. The cylindrical type, a fully porous coated design, cylindrical, and it is used when there is a fracture, there is a long side. There are 2 designs here, a well-polished and fully extensive coated. This is the modular type. As you see, this is replacing a defect in the proximal femur. This is the module when you can do an antiversion. And these are the stems. Also, it is porous coated proximally, fully porous coated with fixation type. And the 6th one is the anatomical curved. Some new versions of the total hip used, and some of them are used as a short stem, and these are controversial. Okay, I'm very thankful for your attendance. So if anyone have a question, please write it down to your chat. I'll be very grateful. Thank you, Dr. Lai. Okay then. Have any experience with the short shanks? No, I don't know. I don't use it. Indication of each design. These are very sophisticated. We usually do as a primary. Thank you, Dr. Hamad Al-Idani. I'm very thankful to you. Actually, where are you, Dr. Hamad? Just in here, yes. Dr. Muhammad Ilani, if you can hear me, I'm trying to unmute you in order to we share our experience together. So that I'm very, very eager to hear your voice. Well, actually, Dr. Ibad, thank you very much, Dr. Hassan Zofi. My question is about the use of modular type in neuromuscular disease. Yes. What about it? It is not always, Dr. Loy. Neuromuscular disorders, we can use the modular type when you have elongation of, or there is a deficiency in the proximal part of the femur. We use the neuromuscular disorder, any neuromuscular disorder, it is very difficult to deal with when there is a lack of the abductor muscles. When there is lack of abductor muscle, actually, the modular tab is a good answer. but you have not interfere with the soft tissue when there is a malposition or improper position of the cup. So you have to put a constrained liner or a dual mobility cup, which is preferred, a tripolar using of the cup in order to tension the soft tissue more. This is one. The second thing is that when you are going to put the head inside your cup, then you can see that the soft tissue will be tensioned according to your length of the neck or the offset. So the offset is now determined well if you have a good cup positioning, not so medialized and not very much lateralized, and the use of the modular type is only for the version and the restoration of the proximal femur. You see I'm saying? Thank you, Dr. Leif. عمي محمد العيداني اضافاتك عمي هسه انا هسه تمنيت انه صوتك طلع.
بعد كده المشاهير اتقدمت امي طبعا كانت عايزه تجوزوني ناخوها بقى
عمي محمد اسمعني
ماليش فيه عيل منزق ومدلع كده بحب الراجل ناشف مظبوط اللي ده بقى اصلا كان شغال في لحد ما قامت الصوت.
هلا دكتور سنان حبيبي شلونك؟
الحمد لله كل شيء
الله يخليك.
الله يخليك.
للاسف النت يعني المحاضره يمكن ثلثها بس افتهمتها لانه النت يروح ويرجع.
انا سجلتها
صوتك يطلع يروح.
I record it and I will share it with you all ان شاء الله.
ان شاء الله ان شاء الله ان شاء الله عاش ايدك ان شاء الله.
ويدك ممنون.
ان شاء الله حبيبي الله يحفظك.
Any few notes if you want to share with us.
لا ما عندي في شيء في الوقت الحالي.
All right.
حبيبي.
All right. We're happy to. There will be the next webinar in the next Friday. It's about my favorite lecture, periprosthetic joint infection.
حلو.
Okay.
Okay.
So we will leave you after your questions, and if you have any that is not mentioned before, you can write it down in the lecture, and I'm happy to answer it. This lecture is recorded now, and when I finish it, I will share in every group you want. If you cut neck low, what do you prevent? What do you do to prevent dislocation? No, low neck cut. Thank you. Low neck cut actually it's about the stem depth or subsidence. It may cause that there is a severe tensioning of the tissue when you are using an extra large one. Or if you do a minus head, not an extra large or a large one, you may have a lack of the soft tissue. Preventing dislocation in a low neck cut. Actually, you can play with the cup positioning first. You have to do it. It is not low or not that high. The second thing is that you have to put your stem in a way that the center rotation of the stem, which means the Morse type, all right, actually the trunnion center is in that line of the tip of the greater trochanter. This is one. The second thing is that the shoulder of the stem from the lateral side into the greater trochanter is no more than 14 millimeter. So that's why you can play with this area. It is not more than 40 millimeter, all right? Less, it may cause a longer part of the offset. You see what I'm saying? If you do, for example, not to deepen your stem away, okay? So you will have a longer offset. This is first. So that's why you can put the stem in shelf with that of the neck cut, all right? So when you have the stem and the trial, you put it inside your femur, and then you can see the length from the shoulder into the tip of the greater trochanter. If it is 40 millimeter, that's all. You are saved. And then put your marker or your imaginary line from the tip of the greater trochanter to the trunnion of the stem or of the trial, all right? and that is a good guide for the neck cut, if it is low or high. Dr. Saif, double wedge system or stem, this is a metaphysical filling only. They are controversial between this and the single wedge. There is no such thing that is an indication, a strict indication for them. You can use it both if there is available. It is only a theoretical advantage why the compression of the and the stress shielding of the proximal part of the femur is higher. Does the modular type can use inversion from arthrodesis of the hip? I'm sorry, I can't get your question, Dr. Lai. Revision, sorry. Use in revision for arthrodesis of the hip. Yeah, why not? You mean that after arthrodesis we can do a total hip arthroplasty? Is that your question? Sorry. I think yes. I think yes. In revision, if you want to revise an arthrodesed or fused hip, you can use a modular type, but actually not the modular stem. I mean that the modular cup, which is more difficult you can deal with. The stem isn't a matter now. The cup is. Yeah, the cup modular, yes, which is modularity of a tripolar or a dual mobility cup. Cause of the soft tissue and the flow of acetabulum as well. Because the flow of acetabulum in an arthrodesed hip, you have to do a very much careful reaming inside the acetabulum, and you will create a new acetabulum, okay, in the true acetabulum where it is fused. And that's why it is very difficult to deal with such cases. ثائر الداهري مشتاقون يا دكتور ثائر. طبعا هسه يلا دخل دكتور ثائر، انا جدا مشتاق لك، واني ان شاء الله يعني اتشرف بك ولو احنا جينا للنهايه بالاسئله. فلهذا اني راح ابلش انه مسوي هذا الفيديو ريكوردد، والخاطر عيونك والخاطر جيتك انا راح انشرها بكل مكان هذا الفيديو. اوكي. مشتاق لك والله. يعني thank you very much a lot and have a nice day. If anyone have a question, those who are coming late, اي سؤال ببالكم احنا حاضرين انه نحكي بيه. زين، واحنا حتكون النكست webinar will be at next Friday about periprosthetic joint infection.
No.
I'm happy to be with you all and thank you very much about your attendance. Late comers.
شكرا جزيلا دكتور سنان، عاشت
I
ايدك.
will you miss nothing actually. جاي متأخرين you miss nothing. This is all recorded. Okay. بلال طبعا همي أنا مشتاق لك أني. زين. This everything is recorded. حتى المشتاق لكم همي أنا recorded. Okay. So you miss nothing actually, and you will have it in the in each group. Each one has their own group, major and minor groups in your special type of groups. This will be recorded and translated to you all. Thank you very much.
Thank you. Thank you very much.
Thank you, Hamid.